Thank you all for joining us today. I am Michael Claiborne, Government Affairs Manager at AMCHAM Korea. Welcome to today's webinar on medical tourism in the COVID-19 era. We are very pleased to offer this opportunity to discuss the important topic of the impacts of the COVID pandemic on medical tourism. We are privileged to be joined by 4 distinguished experts today. First, we have with us Dr. Hee Choi, Chief of Endocrinology and Metabolism at Seoul National University and Chairperson of International Relations at the Korea Diabetes Association, who will be our moderator for today's webinar. Next is Dr. Joong H. Cho, Medical Director and Physician-in-Chief at the International Healthcare Center of Seoul National University Bundang Hospital, who will deliver a presentation on medical tourism reactivation, goals and strategy in Korea. We also have Dr. Wonjae Lee, Assistant Professor at the International Healthcare Center of Seoul National University Bundang Hospital, who will present on hospital preparedness in Korea. Finally, we have Ms. Karen Timmons, Chief Executive Officer of the Global Healthcare Accreditation Program, who will speak about the new normal for medical travel programs in our COVID-19 era. Before we begin the webinar, I'd like to cover a few of the features that you can use during today's Zoom call. First, please note that please note that only the speakers will be visible during the call. All audience displays are automatically turned off. After the presentations, we will have a Q&A session. You will have an opportunity to ask questions. If you would like to ask a question, please use the Q&A function by pressing the button at the bottom of your window. With that, I would like to turn it over to our moderator, Dr. Choi. Thank you.
Thank you, Michael. Welcome. This is the webinar about medical tourism in COVID-19 era, hosted by American Chamber of Commerce in Korea. As every individual in the world got influenced in this COVID-19 pandemic situation, and I think it is like black plague in 21st century. Not only for personal life, but also for the medical tourism field, suffered many difficulties and huge changes in the directions. Today's webinar will be very informative to understand the current situation of medical tourism in Korea and to share real anti-epidemic measure in Korean representative hospital. Lastly, to understand the medical fields of global guidance and standards in this webinar symposium. So without further ado, I will introduce our first speaker, Professor Joong H. He is now the Physician-in-Chief International Healthcare Clinic in Seoul National University Bundang Hospital, and he had been actively working as a cardiothoracic surgeon in Chicago and in Korea more than 35 years. I think he is the right person to talk about this topic because with his long-time experience in international healthcare clinic, he will talk about medical tourism reactivation, goal and strategy in Korea. Dr. Joe, please.
Good morning. Can you hear me okay? So as many of us know, the healthcare disparity between the countries and different ethnicities has been major global healthcare problem for many years. We believe this medical tourism is one of the major tools which can decrease this global disparity issues in international health issues. So in that regard, I'd like to express the gratitude to AMCHAM Korea for organizing conference on this important topic, especially during these very challenging times. The next slide. In recent years, Korea has an increasing number of patients coming from foreign countries seeking medical care. For the past few years, somewhere between 350,000 to 400,000 patients were coming into Korea seeking medical treatment. Economically, generally, the revenue size appears to be close to $1 billion per year, and some of the experts were predicting $2 billion in a matter of a couple of years. If you see the referring countries, it varies from small countries like the Qatar from GCC area to countries like China, about 30%, and half of them may be cosmetic surgery seeking population, but many other countries like Central Asia, Central Asia countries, Russia, and so forth, has been the major source of referral of the patients. But it all changed during this pandemic for the last few months. Since the first case report on January 19 in Korea, which happened to be Chinese patient, we have seen a number of small to large cluster of infection, starting from Shincheonji church activity-related outbreak on February 19, from which the government had to declare the highest alert level on February 23, after which relatively stringent social distancing and isolation rules were applied in the community. And actually, we have been very successful toward the end of April, where a couple of days we didn't see any domestic case occurrence. But after certain, some relaxed rules at the beginning of May, the notorious the nightclub infection occurred, and I think since that time, sort of struggles have been going on. Although we have seen some improvement for the last 2-3 weeks, with average new case ranging between 20 to 110 cases over last 2-3 weeks period. How did it impact the medical tourism industry and imaginable? Although we do not have accurate statistics of incoming new patients during this pandemic, I think we can extrapolate from the decrease of foreign travelers during this few months. For example, in the preceding years, every month we have seen 1.5 million to 1.7 million people coming in and arriving in Incheon airport every month. But if you take 1 month of May this year, there were only about 30,000 people coming into Korea. So from that statistic, I could probably say there will be max maybe 100 plus minus the patient population are coming in Korea at the present time. So the impact was immense, not only the medical institutions, but also the related industries like travel business, food, and translator jobs, and so forth. Next. What does it mean for the frontline workers who are patient and family? In a single word, it means service disruptions. So in terms of delays in diagnosis and treatment, as obviously shown in a number of papers, and such as this paper just published in British Journal of Surgery, and that international survey between March and April for a 4-week period, about 28 million surgical procedures were canceled or postponed, and 2.3 million cancer surgeries were postponed in just 4-week period. So impact is huge. And for countries like Korea, where we never officially restricted any diagnostic or therapeutic procedures or visits, in the 3-month period of March, April, May, there has been somewhere between 20 to 30% decrease in the new diagnosis of cancer, major cancers, such as stomach cancer, 30% less incidence. The breast cancer, 15%. So it means actually there's a less detection of this important cancer diseases during this pandemic. I believe this will translate into less than ideal clinical outcomes upcoming month and years follow-up. In addition to this delay in diagnosis and treatment, the treatment and medical care cost more, and for the patient part, it creates more complexity and inconveniences from which patient, family, or the healthcare workers suffers anxiety and depression and stress. Korea, for the last 20-30 years of what we call compressed modernization period, suffered a number of major accidents and also outbreaks of certain infectious disease, just such as the Seoul ferry boat sinking accident and the major outbreak like MERS in 2015, which happens to be the largest outbreak outside the Middle East. And from this experience, the social consensus developed about the proper governmental intervention and responsibility of each individual citizens. And so consensus developed importance of collective responsibility in this kind of crisis situation. And in that sense, this past experience has been a mixed blessing in preparation of a future pandemics like this. So with the help of National Health Insurance, universal health care by single payer system of Korea, from the lessons we learned by mistakes during this period, 2015, we adopted Contagious Disease Prevention and Control Act, from which number of preventive measures can be taken, such as more hospitals required more isolation bed, and they need to hire more infection control personnel, and they need a regular training of the hospital employees with the possible scenarios, simulations, and proper use of protective gears and so forth. And importantly, the authorities are allowed legally to get the access to the personal information, such as GPS, credit card usage, closed circuit TV information, etc., so that they can use during this pandemic. And these are from the bad lessons, the bad experience during the MERS outbreak, where uncontrolled traffic of the patients resulted in community outbreaks, such as taxi drivers, ambulance drivers, and local clinic healthcare professionals, and so forth. For the institution like the Seoul National University Bundang Hospital, we have an always carrying obligation to the international community as well as the domestic community, in the sense that we have to serve the international community with our medical care for the larger international population by either inbound patient care like medical tourism, or outpatient presence in such as our hospitals in United Arab Emirates and so forth. And through expanding this type of care and knowledge expansion, it certainly translates into the better care for the Korean patient care as well. But there is a certainly concern in that at the current time, the incoming foreign patient population may be source of transmission and as a potential viral vectors and potential source of infection in Korean community. To understand this risk, if you look at the dashboard situation of the current occurrence of new cases, obviously Korea compares rather favorably against some of the countries in South America, North America, Europe, and Asian countries. But still we see somewhere around 20 to 110 cases every day. And it happens to be about half to two-thirds of these new cases are imported cases. So the concerns are real, and we need to be well prepared for such risk in preparing reactivation of medical tourism. The reason is medical tourism is a part of healthcare delivery system in Korea, in the sense that we have to guarantee and pursue the excellent clinical outcomes, not only international patients, and also protect the medical care of Korean patients as well. And as you can easily understand, most of these foreign patients are coming with the number of patient family members together. So there's extra work we need to guarantee safety of these people as the Korean community at large, including hospital personnel, healthcare workers, and so forth. So if you want to open and reactivate medical tourism, we have to open very safely. As I see, there are two ways to reactivate medical tourism during this pandemic. I'm sure there are certain sectors that are very anxious to reopen and rapidly reactivate medical tourism, such as private cosmetic surgical clinics in Gangnam area and so forth. We fully understand those intention to reopen, but certainly I think we have to consider certain prerequisites are necessary before actively propagating medical tourism at this time, such as travel restrictions by the government have to be lifted. And I think we have to see more stabilization of the Korean COVID-19 situation. Also, more importantly, the source countries, the referral countries has to have certain stabilization of COVID-19 status. And also each institution has to prepare better and upscale our preparedness. The other way would be somewhat more conservative approach, since their continuing referral or consultations are ongoing even during pandemic, and we can select those patients who are willing to undergo the required isolation in a facility, after which we can triage the patients with and medical care as usual if they turned out to be COVID-19 negative. But also there are a group of patients who requires more urgent intervention even during this pandemic period. And these patients has to be properly triaged to the medical care facilities. The reason that we have to be very careful is, well, because of the well-known fact that we don't have good treatment modalities in this viral disease. And only tools we have against the virus is to prevent those viruses getting in human body. And the tools we have are rather low-tech and traditional ways of wearing masks, hygiene, social distancing, and tracing, and so forth. And these are the only tools we have at the present time, it appears. So in order to start reactivation of the medical tourism actively, I think, again, we have to have more stabilization of COVID-19, and also the medical institutions have to develop very good planned risk mitigation program and quality improvement program to prevent errors and accidents in the process of this high-risk situation. And we believe our approach will be a layered phasing approach, slowly, with a lot of flexibility depending on the patient clinical circumstances. Just to see the risk of those major referral countries to Korean tourism, excluding China, which has a large population base, most of the countries has relatively low population base. But if you see the number of COVID-19 cases and daily new cases reported daily basis recently, there is still active pandemic going on in most of the referral countries. So to mitigate this kind of problem, I think telemedicine will be an important tool, whether this is simple audio-based telemedical practice or a virtual reality type sophisticated telemedicine. I believe this will be important tools for future medical tourism. Still, there are many legal barriers between the countries, such as licensing issues and so forth. And we are engaged in active discussion with the referral source country healthcare authorities or medical institutions or referral sources at this time. And I think technically speaking, we are well positioned to carry out telemedical care, although we are somewhat behind than United States, where very active telemedical practice ongoing during this pandemic. So for our part, we have been upscaling our communication with our customers and referral sources, keep them appraised of current pandemic situation, both Korea as well as other countries. And also we have been actively upgrading our protocols and the procedure checklist and so forth, and closely monitoring the epidemic situation of the virus on different parts of the world. So for the last few months, we have been upgrading all the protocols from the initial referral of the patients, and also a lot of upgrading of communication was required upon the arrival of patients. And this communication include city government officials, public health officials, not to speak of the internal communication between the doctors and the infection control personnel of the hospitals. Also, the patient assessment should be upgraded, carefully assessing the gravity and acuity of each patient to properly triage these patients. And mostly this involves very active, expanded communication between healthcare personnel and city officials or the public health department who are in charge of facility isolation practice at this time. So through this enhanced communication and the risk mitigation programs, I think we can maintain excellent clinical outcome of our patient as well as other patients in the community and patient family as well. So whatever this new era medical tourism might be, whether it's going to be traditional in-person healthcare or some form of traditional telemedical practice, I believe the key of the success will be the details and how much attention we pay to the details on each step of the patient referral to the medical care. So for the last 7 months, the Korea has been the story of success in the relative sense. I'm sure many countries wants to emulate the Korea's success, but the game is not over, as Yogi Berra said, and this is a long battle, and still there are many potential dangers and risks down the road. And I hope we can eliminate the human errors in terms of each citizen's responsibility or healthcare personnel or policymakers. So all of us need to buckle up, stay alert. And this success we have seen during the past month was due to the hardworking professionals on the front line, such as Joong H, the chief of the Korean CDC, 1989 graduate of the medical school, and other healthcare workers. However, many of us, including those youngsters actively engaged in nightclub activities and so forth, all of us need to be more humble toward this nasty virus, and the spirit well described in the famous poetry by Thomas Nash in 1600. Although we don't necessarily agree with the mass prayer in the closed church space, I think we will certainly need to be humble against this nasty virus, be careful about daily activities. So I will conclude with few take-home messages regarding COVID-19 era medical tourism. I think there is definitely need for reactivation of medical travel and tourism in the COVID-19 era in order to mitigate this healthcare disparity between the international community. With the ongoing unstable pandemic situation of referral countries, aggressive reactivation of medical tourism may carry safety-related risks. International Healthcare Center of Seoul National University Bundang Hospital continue to monitor closely domestic and international status of COVID-19 pandemic and will adopt a safety-focused phased-in approach in stepwise fashion and based on acuity and gravity of each patient we are referred. Upon availability of a new treatment agents or vaccines and stabilization of global pandemic situation, medical tourism will be regalvanized, probably in different form with the implementation of some telemedicine technology and certainly very enhanced the safety focused of prophylactic measures during entire course of medical travel. Thank you.
Thank you very much, Professor Choh. Definitely, medical travel has been obviously decreased in COVID pandemic situation. That's why we are strictly keep our 14 days of self-quarantine process whenever come to Korea. But if the patient case is very emergent, we allow more rapid process through our ER or safety clinic system. Maybe Dr. Lee will introduce that kind of system. So the Q&A session, as Michael said, that after 3 talks, we will have the Q&A session. So please keep your questions in during the active participation for Q&A session. So let's move to our second topic. And our second speaker is Wonjae Lee. He is now assistant professor in Seoul National University Bundang Hospital, and also he's very active interventional cardiologist. And he also graduated he's doing his MBA in Duke University, and he will talk about the real hospital process of anti-epidemic measure, especially for Seoul National University Bundang Hospital experience. Please, Dr. Lee.
Thank you, Dr. Che. I'm Wonjae Lee from Seoul National University Bundang Hospital. It's my honor to speak here today. So today, I'll briefly introduce some of our national system to fight the COVID-19, and I'll move on to the details of in-hospital management system. So this is overview of our Korean healthcare system. So in a word, you can say we have universal care. So government is running national health insurance service, and all the beneficiaries, which is our people, and all the medical institution are under the control of government. So the interesting thing is that more than 90% of our medical institutions are actually private. But since government is controlling the price, they have strive to drive more efficiency with high quality. And our insured, the people, have been benefited from easy access while they're having very high quality care. So one thing I want to note is that while we have 90% of private, but government holds very strong influence over these medical institutions. So what happens when during this era of COVID-19? So when alert level is yellow, we have KCDC controlling the situation with deputy minister here. However, when alert level goes up to red, government sets up National Disaster and Safety Status Control Center, and this is actually governed by our Prime Minister. And our KCDC goes down to control of Prime Minister and fight with COVID-19. So first strategy that our government implemented that we rapidly set up screening center, which are, I would say, frontline for the COVID-19 pandemic. So as you can see, these screening centers are set up around the country, and actually these are all private. And this one here you see is a public. So private and public together, we set up more than 6 spots around the country. And I think now a lot of already know this drive-through screening center, which is very efficient, but at the same time limits exposure of frontline workers to the virus. So if you go into the KCD website, you can search where they are. And currently we are running about 70 spots around across the country. And second important thing is I think this fast introduction of diagnostic kit. I think personally, I believe this diagnostic kits, RT-PCR, for COVID-19 is a most important weapon to fight with COVID-19. So luckily, one of our private company were able to develop this RT-PCR kit in just 3 weeks. And more importantly, after MERS, we have set up something called expedited approval process. So normally, the kit like this takes around 6 months or sometimes 1 year to get approval, but governments work very hard and they have approved just in 1 week so that we could use right away. So by end of February, we were able to have more than 20,000 tests per day. And next is fast tracking and tracing. So I know that there's a lot of privacy issues, but after MERS, we have officially set up Infectious Disease Control and Prevention Act. And under this act, government is able to use GPS, DUR, or credit debit card users data to identify patient movement. So what's important about this is that we know where patient has been there, and then we share this information with the public so that we could prevent secondary or tertiary community spread. And next is restructuring of medical facilities. So I explained that about 90% of private hospitals, private institutions. So we do not have that much public hospitals, but with the start of COVID-19 outbreak, we have set up National Infection Control Hospital. So basically, government transformed these public hospitals just for COVID-19 and transfers the patient to other hospitals. And so I think Dr. Choh a little bit mentioned, so it is very important. If you see the statistics, there are actually more mortality rate increasing during this COVID-19, not just because of virus itself, but because of lack of the other usual care. So government designated safe hospitals. I'll go into detail a little later, but just to give some summary, this is hospital where patients with respiratory symptoms or suspected COVID-19 symptoms are isolated from other patients during entire care process so that they can maintain routine clinical care. And also we have built new units for negative pressure, and because time lag, we transform some of general wards using portable devices to expand negative pressure facilities. And in time of this big outbreak, there's always shortage of medical facilities. So we actually set up community treatment center. This is for management and treatment of mild COVID-19 patients to unburden medical facilities. So this was really a successful cooperation between local government and the private enterprises and also hospital. So this is one example. Our hospital working with Gyeonggi province. So we have set up our control center in our hospital. When we also set up operating center at the site, which was one of the community treatment center. And by telecommunication like this, we could provide patient care for mild cases COVID-19. This is some picture of community treatment center. So we had portable X-ray devices outside the building. And this is a room that was provided to the patient. So when there are very severe cases, then patient in public and private hospital will be transferred to our hospitals like tertiary, where we have very high level ICU unit with a possibility of ICU care. And they get better from our hospital or other hospitals, they'll be sent to a treatment center so that they can get care needed while we can unburden these hospitals. So I'll go more detail into the hospital preparedness. So as I said, SNUBH is one of safe hospital designated by the government. So this is overview of our hospital. So you can see that outside of our hospital, we have set up COVID-19 clinic here. And this is our ER, and in front of ER, we have set up also 3 triage area here. And we have isolation unit in 10th floor in main building. Also high level isolation unit right here, and which is separated from our main building structure. So whoever comes into our hospital, they're all screened at the hospital entry, and there's some suspicion for COVID-19, they'll get tested and sent back home. If they have some severe symptoms, they'll be transferred to ER, and if necessary, they're going to admit it according to one of our isolation units here. So I'll just, this is lobby of our hospital, and this is our entrance. So right outside of this entrance, we have a questionnaire before entrance here. So patient coming in, write down their COVID-19 history or symptoms here, and they're gonna get temperature check right outside this entrance, and they're gonna submit this evaluation paper right here. Then our staff will evaluate, and they're gonna issue pass, or if they have some suspicion of COVID-19, they'll be sent to either clinic or ED triage. This is an example of our screening questionnaire for COVID-19, and this is the hospital entry pass if they do not have any risk for COVID-19. And then what happens at clinic for COVID-19? So whenever there's suspicion for COVID-19, they'll get RT-PCR, and they're going to be sent back home until test result comes back negative. And if there is some suspicion, they'll get some chest X-ray. If not suspected, they'll get issue confirmation for further medical care, so they can go into hospital and get usual care. Or if it is just their simple refill of prescription, they can just get their prescription prescribed right here in this COVID-19 clinic, and they can get back to home. So this was our main building. So outside of our building, we have 2 clinics right here, which is all negative pressurized, and we have X-rays and waiting rooms outside here, so that if there is suspicion COVID-19, they will not enter the hospital but get treated in this area. So this is our ER, and in front of ER we have this 3 triage room. So if there is no suspicion for the COVID-19, they'll go through this area and get usual care. But if they are suspected for COVID-19 or just have some respiratory symptoms, they're going to be use this isolation area. And on admission, we have a 3 category for the treatment of COVID-19 suspected cases. So we have high-level isolation unit, which is for severe confirmed cases, and the renovated isolation unit for moderate confirmed cases. And we have a preemptive isolation unit where people have some risk but not confirmed and need more monitoring. So high-level isolation unit, as I explained earlier, it's located outside of our main building and has separate entrance. This was actually set by the support of government after MERS. So we have a 9-bed right here, and this was set up because to fight with MERS or Ebola, things like emerging infectious disease, but now it is dedicated for COVID-19 right now. So we have a central monitoring at the station, and you can see that we have very big rooms so that you see ventilators here, but when necessary, ECMOs or CRRTs, they can all come in and treat the patient at the highest level. And also we have PPE donning and doffing room equipped. Next is our renovated isolation unit. So this was the word actually used for respiratory patient in the usual time, but as we had a shortage of beds, we transformed some of our general words using the portable devices and converted it to negative pressure beds. And next is our preemptive isolation word. So this is for patients who are not confirmed but waiting for confirmation or came in for other usual care. So for example, in this green area, so patients have some epidemiologic risk factors but asymptomatic, and they're admitted for due to other factors. So they have they need the hospital care, but they are not confirmed COVID-19 cases, and we're gonna put them here until the test comes negative while continuing necessary treatment. And face-to-face consultation in our hospital actually has not been that changed because we have a screening system to prevent suspected COVID-19 from the hospital. So most of our in-hospital care is maintained in usual way. But anyway, still there is some difference. Now doctors, patients are all wearing masks all the time. We're using hand sanitizer every time comes in and goes out. Definitely there are more frequent hand washing. So there has not been dressing change, but there are more emphasis on principles. And now we're implementing telemedicine for the time of COVID-19. So if patient cannot come to hospital, we do phone call with patient, and we're gonna send prescription to nearest pharmacy so the patient get the prescription filled without coming to our hospital. But this is only for clinical stable and need prescription filled for the same clinical diagnosis. Definitely we're doing cleansing and disinfection all the time. And this is a picture of our actual cafeteria. We have all the blocking panels so that to minimize any transmission during lunchtime. And definitely always we are wearing all masks and hand washing all the time. And we have converted our all conferences and meetings to teleconference so that there is a minimize their possible transmission between our medical staffs. We have provided a lot of education and training for healthcare workers like this. This is a picture of a patient doing CPR while wearing these our PPEs, and also this is an example of transferring patient who has COVID-19 confirmed case. So I'd like to close my talk with a case that we recently have. So there was a 7-year-old Russian boy who has an advanced cancer. So he already went through multiple surgeries, chemotherapy, radiotherapy, and more in Russia and recently in China. However, cancer was progressive, and actually he was recommended to go home as there is no available treatment. But as you can see, this very small young boy, patient mother strongly wanted second opinion, so they contacted our International Health Center of SNUBH for help. So our staff consulted oncologist, and luckily decisions were made that we're gonna do secondary evaluation for the patient in our hospital. So our coordinator communicated with the mother, and patient safely arrived in Incheon airport and moved to quarantine facility. So normally, if it is not emergency, patient has to do 14-day quarantine. However, since this patient has advanced cancer and has a very severe pain due to cancer. So the control center contacted our team whether we can treat the patient. So our staff coordinated with the specialist and the infection team right away. So the specialist concluded that patient needs to be admitted, and infection team recommended, if necessary, patient should come to our preemptive ward. So patients were transferred to our ER, and since he had a suspicion of COVID-19, he was sent to isolation ward. And then right after some basic tests, he was sent to our preemptive wards where he can get more treatment. So luckily, he was tested negative COVID-19, and evaluation went on like CTs and MRIs using these kind of tools. And then there was a multidisciplinary team discussion. Here you see oncologist here, here's a surgeon, there's a radiologist, and this is our staff at IHC, Dr. Kim Sergey. So they decided we're gonna give a chance to a boy, and we tried chemotherapy and radiotherapy. And luckily, as you can see here, the tumor size has greatly reduced, and more importantly, when he came to our hospital, he was on a lot of opioids and narcotic analgesics, but now there is good response. He's now free from these medications. So I think it is our time to adapt to new normal. So, well, in the hospital, we may maintain our usual care, but we're gonna now have to go through these COVID-19 clinics or some screening centers. And whenever coming into hospital, we're gonna go through all the screenings. And also, when patients travel to our hospital, they're gonna have the 14 days screening. So I don't think we'll be able to go back to this intimate environment and usual care, but some of transformed form of care. But I think we'll stick to the principles. I think we can go through this tunnel very well. Thank you.
Thank you, Professor Lee. Introduced a very detailed process in Seoul National University Bundang Hospital. And especially as I mentioned, we keep 14 days of self-quarantine process for elective cases of patient. But as Dr. Lee mentioned about the 7-year-old boy with cancer and emergent therapy, he actually skipped those kind of process and go to the emergency room according to the triage. So maybe we will discuss more about those kind of cases. So let's move to our last speaker. And I want to invite Karen Timmons, who is currently the Chief Executive Officer of the Global Healthcare Accreditation, GHA program. And she will talk about the new normal for medical travel program in our COVID-19 era. Karen, please.
Thank you very much. I'm very honored to be with you today and appreciate the opportunity to participate in this impressive conference, especially being held in South Korea, which, as has been introduced, is really a leader during this time with COVID-19. GHA is an organization that focuses only on medical travel. Many other organizations accredit hospitals and clinics, and our focus is on the medical travel program and helping organizations improve the patient experience. Our difference is the clinical accreditors really look at the broad quality and patient safety infrastructure. So they're looking whether or not that organization has existing infrastructure to support good quality and clinical outcomes. GHA does a very deep dive with respect to the medical travel program, and we only accredit hospitals that already have an existing clinical accreditation for that purpose. So someone might have a national accreditation from their national body, might be an international such as Accreditation Canada or Joint Commission International, but we only work with those who have a clinical accreditation in order to reach GHA accreditation. Our standards have been accredited by ISQA, which is the accreditor of accreditors internationally. Now you might say, well, why is there a need for a medical travel accreditation program. And historically, there has really been no international best practice for medical travel. And I think as some of the speakers before me, Dr. Lee and Dr. Choh, have mentioned, medical tourism is a very complex issue. As you can see on the slide, it certainly starts well before arrival at a hospital. Think of a patient, the mother of the child that Dr. Lee mentioned might be sitting at her kitchen table looking for opportunities to address her son's issues and wondering what country, what organization might be best for her son. And then there goes to the phase of, once they have decided on a particular organization, sharing that information and data to determine whether it's appropriate for that child to arrive at SNUBH. Then there's the complexity, added complexity of the logistics of travel, of how to travel, accommodation, and admission, treatment, and discharge. And these three circles are the normal areas that a clinical accreditor would be looking at. And GHA looks, right, our standards follow the path of the entire care continuum, all the way from that getting that search all the way to follow up back home. And we also look at things such as ethics, marketing. We want to make sure that what is represented on an organization's website does have integrity. We want to make sure that there's areas such as language competence, cultural competence, communication, education, travel, and tourism are all being considered in this area of medical travel and medical tourism. From the patient perspective, we're really looking to enhance their patient experience, mitigating the risk along all of the touch points that are involved with medical travel. From the provider perspective, we're helping to improve the organizational performance to deliver good patient experience, bottom line performance, as well as obviously good clinical outcomes. And research has certainly demonstrated that better patient experience correlates, not surprisingly, with better outcomes and financial performance. And we also look at buyers having a network of organizations that they might want to be aware of, since they have looked not only at the clinical and quality perspective, but at the entire patient experience. And some of you might be saying, well, is it really that important to have a patient perspective? And we've had some of our hospitals that we work with say that when they did the follow-up survey, they were very surprised not to get a good result. And when they really drilled down as to understand, why a patient might not have scored patient experience or their satisfaction that high, it wasn't because of the clinical care that they received at the hospital, but it might have had something to do with the hotel or the communications. And so the hospital did not really realize that all those aspects were counted in that entire experience of the patient. So it's important for hospitals and clinics to pay attention to the entire spectrum of the care continuum. So we are here today to talk about how to manage COVID-19 in the post-era, or certainly to live with COVID-19, because as we have seen in the past 6 months, it's a dynamic situation, and we probably will be living with it for some time. It has transformed life as we know it, and as the previous speakers have mentioned, both healthcare provision, travel, the economy, social norms all over the globe have really changed dramatically. And it's important for us to understand how best do we adjust to the new normal. And while the situation in many parts of the world continues to be uncertain, some regions and countries such as South Korea and other countries in Asia as well are reopening their medical travel programs and opening their opportunities for elective surgery. And we also are seeing that it is a very dynamic situation. And so we really need to understand what to do to reduce risk and to carry on as normally as we can, but with a real focus and intention to mitigate that risk. And medical travel programs must make intentional decisions and take deliberate actions for sustainable recovery now. And as Dr. Choh, I think, said several times, there are, challenging health inequities around the globe. Some patients might be looking for care because it's not affordable within their own country. They might be looking because it's not accessible. It might might have too much delay, even though the government might pay for it. Others are looking for a higher quality or for treatments that aren't available within their country. So there's many, many reasons and rationales and motivations that a patient might have to travel for their care. And without medical travel, they might not have any opportunity for that care to occur. Now, I think the other speakers have talked very well about what the monitoring system is as visitors enter South Korea, but it's been interesting to me because each country really does have the criteria that visitors must meet as they enter, and many of them obviously have the 14-day quarantine as well. I think the one thing that struck me obviously is the app onto the smartphones. And, you know, the US certainly is lacking that. And certainly I think it does help with the trace and isolation if someone does test positive. GHA, in working with some of our clients during the initial few months, they were asking for, well, what are the best practices right now? You know, how should we be reacting? And so what we tried to do is to develop operational protocols, very specific operational protocols that would help during the day-to-day work procedures as hospitals and medical travel programs resumed their medical travel programs. So this is not a presentation on the treatment, as Dr. Lee was talking about, of treating COVID-19, but what are some of the processes that should be looked at for the medical travel patient? And so the guidelines provide specific examples of structures that programs should consider based on international authorities, in addition to selected GHA standards that help mitigate risk to patients. As I mentioned, we have the medical travel care continuum, and we developed our guidelines based on each of the components. Each circle has different guidelines that we have developed. And then we are offering a certification of conformance against those guidelines. The guidelines we have issued free of charge. They're available for free on our website. But some organizations are saying they really would like a certification that they have cleared those guidelines. They are in complete compliance with those guidelines as a way of building confidence and trust with patients or buyers that this medical travel program and hospital has had an external validation that the protocols and practices and procedures that they have in place reflect international best practices designed to keep traveling patients safe as programs are resuming their operations during or post COVID-19. And we based our guidelines on our standards, and many of them, and the standards are based on 3 core competencies: care management, patient experience, and sustainable business practices. And normally standards are written in a way that has some flexibility for organizations to comply with. But the GHA COVID guidelines are much more specific to, obviously, a pandemic, and are based on referenced international authorities, again, to help mitigate the risk to patients. In addition to the GHA standards, we have utilized references to these international organizations that have issued guidelines as well. I'll review these very carefully, and I think Dr. Choh is very clear in saying as a medical travel program reviews whether or not it is ready to reopen, there are some general things that they need to be considering. And we had 5 criteria that we're asking that the medical travel monitor and really consider as they're opening their hospital or their clinic within the medical travel program. So that the hospital, that they are in a geographical region which has experienced a sustained reduction in the rate of new cases for at least 14 days, that they are in compliance with their local or national authorities' mandates or executive orders. Obviously, each country might have different executive orders, so that hospital has to be aligned with those. That the hospital or clinic continues to monitor their COVID-19 rates to ensure alignment of the program's protocols with the updated mandates in the event that any revisions are necessary. that they are in compliance with national or international regulatory recommendations regarding the treatment and prevention of COVID-19. And I think Dr. Lee, in his presentation, was really talking about many of the best practices with respect to isolation wards and reviewing the patients as before they entered the building, and that sufficient resources should also be available to the organization before they reopen so that they know that they're going to be able to keep their staff safe and also patients with respect to PPE. So again, this is the medical travel care continuum as we move forward. In that phase 1, which is the service destination selection, we're asking that, we're looking for organizations, medical travel programs, having special messaging, whether it's on their website, whether it's in their communications with patients that might have templates that they're using, regarding protocols or special arrangements that they have developed or plan to be developed, and that they might have social media channels that they might be using to target their audiences, that country audiences of their medical travel program. And this would include information about COVID-19 pre-screening and testing policies. It might include the use of potential telemedicine, telehealth, what safety protocols have been established along the entire care continuum. And Dr. Lee highlighted certainly some of them very well for Bundang. What workforce safety strategies are in place to keep the workforce safe? Are there any travel restrictions or quarantine? So you'd be very transparent about the 14-day quarantine, the use that the patient responsibility might have in traveling so that they're using PPE equipment and masks, etc., on their travel to the country. And one thing that doesn't get a lot of attention sometimes, but be transparent about visitor guidelines. Obviously, one of the speakers mentioned that there's usually additional family members that would travel with the patient. Some hospitals might right now have no visitor guidelines. So I think it's very important to be transparent to the patient and to the family as to what are the guidelines with respect to visitation, and would they be allowed in? Are there more constraints during this time or not? And so as many hospitals are revising their visitation. And also special attention to sanitation and cleaning. Just in why you might say, is this so important to put on the website? Well, certainly will help build that feeling of trust and safety in the patients and potential travelers who would be traveling for their care. During phase 2, and this again is the phase where patients have selected the country and the organization and are going through that exchange of information to make sure that they are eligible for treatment, and for the hospital as well to ensure that they are the right patient at the right time for the specific treatment. They might need to be pre-screened for COVID-19 during pre-admission, and whether it's done at the country before their visit, and as well as being done before they have their treatment, that should be revealed to the patient. Reassessment of comorbidities wouldn't necessarily need to also be reviewed, especially if there's been a delay for several months in the care. As Dr. Choh highlighted, there have been delays for in testing and diagnoses, so tests might need to be repeated, certainly if there's been a delay of a certain period of time. And also to talk about the potential of where the patient might need to go for post-acute care recovery, whether it's a skilled nursing facility or rehab medicine, and how safe that organization might be, or whether it's the recovery would take place within a hotel or within the hospital itself. Also, that the medical travel program would provide a detailed itinerary and care plan talking about how the length of stay might be impacted. And obviously, if the patient tests positive when they arrive in the country, what is the impact of that? And what is the financial responsibility if the patient is sent home? And this is just to be transparent so the patient is aware of the consequences of some of these things happening and also understands the financial implications. So it's really, we're asking that these types of things be shared very concretely. And many, some of the organizations that we're working with have had, new consent forms developed so that patients are signing that they are aware of this, so that if they are sent home without the treatment, they understand that this was a potential before that happens. And also that they have protocols during the travel, so they know what to do during the airport and their airplane ride, so to mitigate any potential risk of infection. And we talked about this. And I just listed it here so that, each organization might have their own protocol, but obviously it's to be aligned with the international best practice as far as infection mitigation. And again, I mentioned that, patients should be aware of the potential consequences should they test positive upon arrival and having to go back home or maybe treated somewhere else within the country before they might stay for their treatment. So there's different consequences, and that they might necessarily understand these before they determine that they are going to come. When they arrive, that the meet and greet personnel are trained on and follow safety protocols. So are they being trained by the hospital or the clinic, whether or not they are their own employees, or some hospitals might contract this out, but they still should have a protocol in place, as well as with the ground transportation personnel, so that they're trained on and follow safety protocols and facilitate compliance. With respect to accommodation at hotels, many medical travel programs might recommend hotels, or they might own a hotel. And really, it's up to the hospital to have criteria in place to ensure that hotels are complying with recognized industry-wide hotel cleaning and sanitation standards required by COVID-19. Because obviously, the worst thing would happen is they're staying in a hotel that might not be as safe for them as certainly the hospital is, and we would not want any risk of contagion at that time. So we're really looking at, again, that entire medical travel care continuum and trying to ensure that there are protocols in place for their safety. And there are numerous organizations right now that are specializing in the sanitation for hotels. And so we're just asking that there be a recognized international or national standard and criteria that are being used during registration. And certainly, I think you've seen a fine example of how there's a protocol in place to make sure that there's safety and pre-screening for patients before they enter the hospital about their symptoms, and adhere to the hospital and clinic policies regarding what they need to do to mitigate the risk of infection. They might have rapid testing. There might be a need for post-operative or post-treatment COVID testing as well, and that the medical travel program has established a protocol to follow in the event that testing is positive, as I mentioned earlier. And also, again, the need for protective equipment when while the patient is during their stay at the hospital. At discharge, there might be certain clinical instructions that are necessary for the patient in order to follow with respect to recuperation, travel, or additional testing before they go home, to make sure that they and their companions have sufficient masks in order to while they stay in the country, as well as for their travel back home. If they are referred to a skilled nursing home or another facility for recuperation, that the organization is monitoring that for COVID-19, and they're monitoring the referring facilities appropriately, and other ancillary service providers as well. And that information should be shared if there's any local endemic areas as well. There might be a need to provide a fit to fly letter for the patient depending on their country of origin. And again, the patient should be informed of the safety protocol as they fly back home. And just briefly, as I mentioned, we do have a certification of conformance against these guidelines. We will be announcing our first organization that has achieved that within the next few days. And again, the purpose of this is to provide a third-party external validation that a medical travel program, certifying that the medical travel program has effective systems, work processes, and protocols in place that will facilitate the confidence and trust of patients, buyers, and key stakeholders, and facilitate transparency with patients by communicating, as we talked about, some of the financial arrangements, the specific protocols for travel and accommodation, and what their responsibility is while traveling as well. It assures that hotels accommodating your medical travel patients are following internationally recognized guidelines for sanitation and safety. And it also will educate and train your medical travel program staff by providing guidance and work on these work protocols and processes. Within the benefits of the certification of conformance, we include free training on the certification. It's embedded within the program. It's all online. So they would complete a readiness assessment form. They would submit the requested documentation, and we would have a virtual validation call to see if they are on board with all of the areas of the guidelines. And this is just how, you know, you would go to our website, and certainly we'll be interested in responding to any questions you might have. And I will stop my screen sharing and turn it back to the moderator.
So thank you, Karen, for introducing very intensive global standards for COVID-19 in medical travel. So I think there are many new words coming out in this COVID era, like a new normal and untact, the kind of new terminologies coming out. And maybe we should ready for those kind of new normal in even our field in medical tourism. Okay, I will start the Q&A session of today's webinar. Please turn on your microphone, or you can type your question in the Q&A button, or you can make a chatting to us. Please feel free to ask any questions you have.
I have a question to Karen about this additional certification of COVID-19 era. How was the response to your announcement of these guidelines from the frontline, the medical travel, you know, organization? Usually this accreditation requires on-site visits, and are you doing this online or actually doing visits? So I would like to hear your answers about that.
Yes, thank you, Dr. Choh. This is a completely online process. So the organization has to submit evidence, and we have a list of documents that we are requesting. So they have to submit evidence that they are in compliance with about, I would say it's like 14 areas. And we review that. And then we do have a virtual validation interview, like a Zoom call with the organization. So if we have any questions, they would have an additional period of time if they're not in compliance. But we recognize during this period that traveling is not feasible, really. And we are trying to make this a value to organizations. We have priced it for a virtual virtual experience, and we have had quite a bit of interest, and we already have about 6 organizations that are in the process right now, and one has completed the process, and we are very pleased. Dr. Choh and some of his colleagues reviewed the guidelines before they were issued and provided some expert input. So we're very pleased. And obviously, I hope everyone realizes that Bundang is a GHA accredited organization in compliance with all of our standards. So we're delighted, especially to be sharing the screen with one of our clients tonight. Thank you.
So is there any questions from participants? Okay, if not, there's one Q&A typing questions, and maybe Dr. Lee can answer this question. Should serology test to be implemented as a complement to RT-PCR, and especially for the tourist travelers can be accepted for this kind of serology testing? Can you answer this?
So my answer is no. The serology test doesn't. It's usually becomes positive around 1 week, at least a couple of days, and sometimes a week to be positive. So it cannot reflect this real-time infection. And then the testing has some limitation as well. Just having the positive serology test does not mean that patient will not be infected. So I think for now, RT-PCR is the standard and has to be still implemented for the tourist travelers.
Maybe the person was asking the question in the sense some of the countries have very long turnover time of this PCR tests. So, you know, for like Korea, it will take about 5 to 7 hours to have the results back. But some of these different countries have a very long period of time to get the results. And that's maybe the problem in practical sense for the travelers and so forth. So.
Yes, that's true. But still, the positive or negative testing itself will not reflect current situation. So it can be just only complemented when RT-PCR is not available, but still has a lot of limitations.
Yes, that's true. In case of Africa, there's only 2 or 3 RT-PCR facility in entire land, I understand. So if there's some area they have some fever situation and they are not for sure that it's COVID-19 related, in this kind of cases, serology test is maybe have some kind of the values. But definitely in Korea, every personnel who come to our country, we should do to test for the COVID-19 RT-PCR test. We do not use any serology test for the diagnosis. It can be the answer. Okay, there is another question from Park, and maybe she want to hear more about what is the truly urgent cases. So, and also those kind of urgent cases is only for the persons who are like Koreans living abroad, or only to non-Koreans and whatever it is. So maybe it's a matter about the kind of triage and the 14 days of quarantine system, it be mandatory or not. So Dr. Lee, can you answer this question?
Okay, so this is actually a very hard question because it's really hard for us to say which is really, really urgent or not. So the Park actually mentioned that aggressive cancer in need of surgical treatment as soon as possible, but has no issue with morbidity. I mean, I think it should meant to mortality. So I think it's really the comprehensive discussion between the infection team and also the specialist for oncologist. So if all the team thinks that this is really urgent case, I think that becomes urgent case, and we can bring the patient in our hospital and do more August testing. And while doing that, we're going to put them in preemptive work. So I think it's really case by case, and it should be, the answer always will come out under the multidisciplinary team approach.
Yeah, I do agree the Dr. Lee's opinion, because actually there's so many different cases had been happened even for the cancer patients. So if it's really emergent situation, we do allow those kind of passing 14 days of quarantine. But in other cases, we should keep those kind of 14 days of quarantine for visiting hospital. So if this COVID pandemic situation is rapidly getting better after proper vaccination or treatment method, it will be very good. But I think this unusual situation might be staying longer than our expectation. So I have to ask about some kind of future direction of this medical travel, such as telemedicine things. So I've heard that there's a lot of requests from other countries about the online consultation or consultation they happen. So, and also there's many participants from IT companies, from my understanding. So maybe they are very interested in the telemedicine and the current situation, telemedicine in Korea. So Dr. Choh, can you comment on this?
I think the telemedicine is a very important tool, and it will be a very effective tool. The only difficulty would be how we effectively utilize between countries and so forth, between different politics, diplomacy. But I think the best way to go about is some international consensus should develop between the healthcare workers or government. But this decision and discussion should occur and also have to be based on patient-focused, in the sense that politics aside, money aside, I think we need to serve the patients at disadvantage in different parts of the world, in the sense that how we can better serve using this telemedicine technology. So let's say there's a controversy about the reciprocating licenses and so forth, and we have to understand this issue. But in some degree, like United States, between the states, they have to resolve this issue rather fast to facilitate the telemedical process between different states and so forth. So I think similar type of work and discussion has to occur very soon between the medical community and political community, in the sense that, legal community, in the sense that we can develop plans or treaties, whatever, then the decision should be focused on patient care.
Okay, thank you. For example, in our hospital, we are also preparing this telemedicine things for the foreign medical travel and even in the domestic things, but it's not, it has more decisions should be made. So we did not do right now. It's only for the emergency cases or other cases that Dr. Lee introduced in some kind of exceptional telemedicine cases. And Rodrigo has another question about how do you know if the patient has built the antibody after treatment? So Dr. Lee can answer this question. We usually do the repeated RT-PCR test, right?
So to know that patient is negative for COVID-19, we do 2 consecutive tests in 3 hours for RT-PCR. So whether they have developed this, the antibody, yes, we have to do serology test, but still the clinical implication for having this antibody for COVID-19 is still not very clear, whether it's very protective or it's still not very clear. So currently we are not doing routine serology tests in Korea, but just doing RT-PCR to see that patient negative for the COVID-19.
Yes, that's true. So just for the research purpose, we do the serology test that how many percentage of the population have those kind of a serology positive for COVID-19. But it's not a neutral antibody yet. We are not for sure that. So if you have antibody and you do not getting any disease, and we are not for sure this kind of things right now. So we only do RT-PCR tests for confirming the negativity of COVID-19 virus. So, okay, if there is no more questions, maybe I have to close this webinar session and give my microphone to Mr. Michael Claiborne for the closing remark.
Thank you, Dr. Choi, and thank you to all of our panelists and our moderator for the great discussion. I think that brings us to the end of our webinar. So I'd like to thank all of our audience for tuning in today. Please have a great day.